Hi, I'm Michelle Kittleson, Professor of Medicine at the Smith Heart Institute, Cedars-Sinai, Los Angeles, and Associate Editor for JACC. I'm delighted to be joined today by Dr. Mathew Maurer to discuss impact of heart failure severity on vutrisiran efficacy in transthyretin amyloidosis with cardiomyopathy. This study will be presented at the American College of Cardiology annual meeting with simultaneous publication in JACC. Dr. Maurer needs no introduction, but I'll introduce him anyway. He is the Arnold and Arlene Goldstein Professor of Cardiology at Columbia University Irving Medical Center, where he directs the Clinical Cardiovascular Research Laboratory for the Elderly and is director of the Cardiac Amyloidosis Program. Safe to say that pretty much everything we know about cardiac amyloidosis is directly or indirectly a result of his amazing work. And his other amazing superpower, which truly endears him to me, is that he's the quickest email responder east of the Mississippi. I add that qualifier because I think I hold the Western regional title. So the HELIOS-B trial. Oh, yes, go.
Michelle, you'll hold the overall title, truthfully.
Okay, thank you. I didn't want to be too presumptuous. Amazing. The HELIOS-B trial was a randomized controlled trial of vutrisiran versus placebo in patients with transthyretin cardiac amyloidosis. In an amazing win for patients with ATTR cardiomyopathy, vutrisiran was associated with a significantly lower risk of the composite all-cause mortality and cardiovascular events. Treatment also preserved functional capacity and quality of life. In this pre-specified analysis of HELIOS-B, Dr. Maurer and colleagues assessed the effect of vutrisiran in patients with different heart failure severities. They discovered that across NYHA class, NAC stage, NT-proBNP tertiles, there was benefit of vutrisiran in all-cause mortality and cardiovascular events, as well as KCCQ and 6-minute walk test. So here's my first question for Dr. Maurer. Keeping in mind that patients with NYHA class 4 symptoms or class 3 and NAC stage 3 were excluded, how should these findings assist clinicians in caring for their patients with ATTR cardiac amyloidosis?
Yeah, a great question, Michelle. And I think you highlight one of the slight limitations of this study. We've learned over the years that in amyloid, earlier is always better. And in this particular design, we excluded, obviously, people, as you said, who had NYHA class 4, and even those with a class 3 heart failure had elevated NAC stages, particularly, for example, people with NT-proBNPs over 8,500 picograms per ml. Those aren't patients who do very well with any disease-modifying therapy that we have, to be frank. If they're appropriate candidates for cardiac replacement therapy with transplant, that would be very reasonable. I do think that these data, because they're not only pre-specified, but many of them are exploratory, in which we looked at many different ways to assess the severity of a complex clinical syndrome such as heart failure, do suggest that vutrisiran, as you said, was quite effective across the spectrum of disease that is enrolled in HELIOS-B. And we still have, in some of the parameters, I think, a signal that while there wasn't heterogeneity, for example, across New York heart classes, there was some heterogeneity, for example, across NAC stages, still reaffirming the idea that earlier is better. So I still encourage clinicians really to put amyloid on their differential, try to identify people as early as they can, and think more about active surveillance programs than a circumstance in which someone, God forbid, comes in your office in a wheelchair with advanced disease.
It's almost like you knew the second question I was going to ask, because you've led me right to it, which is, speaking of these patients with severe disease, and given that vutrisiran doesn't reverse disease, do you think there are patients for whom the current landscape of therapies, the stabilizers and now the silencers, should not be offered to patients?
Yeah, it's a great question. I think, to be honest, other countries have done a much better job at possibly limiting what is, as we know, very expensive, but also very well tolerated therapy. I mean, if cost wasn't an issue, I wouldn't have such concerns per se, but we do have to, I think, put on our health economic hat a little bit. So there are definitely patients, I think, who are past the pale, and clinicians should have honest discussions with them. You know, the old shared decision making, not I made a decision and I shared it with the patient, but rather I actually sat down and talked to someone, explained to them that they might live a little bit longer, might is the key word there, especially with advanced disease. It takes a long time if there's any effect, but they're going to live in a state that they may not particularly want to be in or enjoy. And so those honest discussions are important. The good news, though, I would say, is that we're really seeing much less of those folks in most of the amyloid programs. And so hats off to all the clinicians out there who've begun to, find patients, think about this. And the percentage of patients, at least at our center, who have truly advanced disease is now below 10%, which is great.
Amazing. So these results are actually really helpful because there's a vanishingly smaller group of patients who seem to be at the point of no return because clinicians are getting so much better at recognition and diagnosis. And I have one last question for you. I can't let you off the hook without picking your brain on something everyone who takes care of patients with amyloidosis is really wondering about. We know that about 40% of patients in the HELIOS-B trial were receiving tafamidis at baseline, about another 20% started it during the trial. The pattern of risk reduction was comparable in the overall population and the monotherapy population. Do you think there's any insight we can find on the role of stabilizer versus silencer therapy and or both in patients with ATTR-CM?
Yeah, unfortunately, I think this data is limited because, as you're pointing out, it's only 655 subjects, and then you're getting into smaller subgroups with really, very, very limited power. Comparing the two, I think, is impossible because, they weren't stratified on that particular grounds. The combination group, there was some Kaplan-Meier curves that were presented that numerically suggest that there's a lower event rate. It's nowhere near statistically significant. The good news is we have another trial coming with a larger N, more than 1,400 patients, of which, if this holds up, probably 70 or 80% will be on background tafamidis therapy, which is at this point stabilizers considered standard of care, and hopefully we'll get a hint about combination therapy. I struggle with it because we're back to the cost issue. And then I also attempt to use the analogy that we do in HFrEF, which is we don't wait for people to get worse to give these drugs. We give everything all up front. The bottom line is there's a lot to be discovered in this particular field as we get more and more effective therapies. And that's great for patients and their lovely families.
Amazing. I know now everyone in the audience who's listening now is as big a fan of you as I am. Thank you so much, Dr. Maurer. That was amazing. We learned so much.
Absolutely my pleasure. Thanks for your enthusiasm and your expertise.